We'll just give it a few minutes for all the attendees to come in.
Yeah, sure. So I'm waiting for you. Is that right? Your cue?
Yep.
Yep, that's fine.
Everyone's just joining now. Hi, everyone who's already in. Hi, everyone. Thank you very much for joining us. My name is Catherine Bennett. I'm the Head of Marketing and Communications for EBOS Group's institutional healthcare business, which includes HPS Pharmacies. This is a HPS Pharmacies webcast lecture. This educational presentation can be used to contribute to your CPD hours to meet the standards set for professional registration purposes. We are recording this lecture for on-demand playback, and notes will be available by emailing us following the event. A prompt will be sent to you within 24 hours, so please just request it then. Now it gives me great pleasure to introduce our speaker for today. Lisa Rudolph is the Pharmacy Manager for HPS Pharmacies Richmond. You can see Lisa there in the video.
Hello everyone.
Lisa will discuss buprenorphine depot formulations. Our agenda also allows a 5-minute Q&A at the end. If you navigate to the bottom of your Zoom interface at any time during the presentation, you can type in your questions or you can wait for the Q&A timing. We will monitor those questions throughout and ask them towards the end. We can't see you and we can't hear you. However, if you've got quite a long question at the end, let me know by putting up your hand and we can allow you to speak. So turn your audio on. So we hope you enjoy this presentation and find it useful to your practice. Thanks again for joining us. I'll now hand over to Lisa.
Good afternoon, everyone. Welcome to today's session on buprenorphine depot formulations. So a little bit about myself. So my name is Lisa Rudolph and I am a registered pharmacist. I've worked in clinical hospital settings for the last 15 years. And in addition to that, I have over 10 years experience in community retail settings. In my current role, I am the pharmacy manager at HPS Pharmacies in Richmond in Victoria. So there I lead a team of pharmacists and technicians in servicing 2 psychiatric facilities in inner Melbourne. So the Melbourne Clinic and its sister hospital, the Victoria Clinic. The Melbourne Clinic is the largest private psychiatric facility in the Southern Hemisphere. And within it, it has a substantial substance abuse department that's overseen by psychiatrists and addiction specialists. It also runs a substantial outpatient substance abuse department as well. Now, I think that the introduction of long-acting injectable buprenorphine is a game changer. I have personally seen the demand for this product just explode over the last year. And I guess it's a product that is patient focused, and it's about giving patients autonomy, choice, and the patients are no longer bounded, bounded by daily pickups from their pharmacy. So hopefully you can walk away from today's session feeling that a significant milestone has been reached in the treatment of opioid dependence disorders. As Catherine has mentioned, this session will be recorded. So if you need to go back, please reach out to Catherine. Okay, so let's get started. So opioid dependence is a chronic and relapsing illness. In terms of the philosophy behind treatment of opioid dependence using opioid replacement therapy, it's about harm minimization. So reducing harm to the individual as well as reducing harm to society. There are a wide range of benefits from this type of treatment, and they include reducing drug cravings and withdrawal symptoms, reducing criminal activity in society, avoiding unsafe injection practices, and improvability to maintain employment and education for those individuals, and ability to maintain relationships for those individuals as well. So looking at opioid replacement therapy, both methadone and buprenorphine are agents that are utilised in as a prescribed substitute opioid. Now, whilst methadone is a full opioid agonist, buprenorphine is a partial agonist. And what that means is that when buprenorphine occupies an opioid receptor, in particular the mu receptor, where it is a partial agonist, it has a lower intrinsic activity compared to a full opioid agonist. And importantly, what that means is the patient will not feel that huge euphoric effect they get when they have an agonist, and there is the reduced high effect. Now, buprenorphine also has a high affinity as an antagonist at the kappa and the delta opioid receptor, and with these type of effects, there are a number of different properties that buprenorphine exhibits. One is the ceiling effect for respiratory depression, and what that means is it's a safer product compared to methadone. It slowly dissociates from the opioid receptor and therefore has a milder withdrawal effect. And because it occupies the opioid receptor with such high affinity, it reduces other opioids from occupying those receptors, and therefore reducing any positive effects from other opioids. Now, because buprenorphine occupies those receptors quite with such a high affinity, can precipitate withdrawal. So it is normally recommended that when buprenorphine is initiated, that it should be started once the patient already shows signs of withdrawal, rather than shocking that patient's system into withdrawal. So let's look at the different formulations for buprenorphine opioid replacement therapy. So traditionally, buprenorphine has been available sublingually now for almost a decade in Australia. Initially, it was available just as a single agent formulation in Subutex, and over time, Suboxone was introduced, which is the combination of buprenorphine together with naloxone. Now, the reason for that was because a lot of patients were diverting the sublingual tablet, the Subutex, just the single buprenorphine tablet. They were diverting it for drug use and injecting it. So the naloxone was added, and in the Suboxone range. And what that means is that if the patient were to have it as they should sublingually, the naloxone is inactive, so it's poorly orally absorbed. However, if the patient were then to inject it, the naloxone becomes active, and it would actually stop the opioid action for someone who was opioid dependent, and would delay opioid effects for someone who was opioid naive. Now, buprenorphine is absorbed. The bioavailability of buprenorphine is quite poor orally. That's why it has to be used sublingually. Now, both Subutex and Suboxone are intended for daily administration, although you can get away with every 3 days, but it's not often seen. The Depo formulation definitely overcomes this issue of daily pickups, and is obviously a more convenient option. So let's look at Depo Grippanorphine. So there are 2 products that are available on the Australian market in terms of Depo Grippanorphine. You have Sublocade, which is a monthly injection, and you have Buvidal, which is a weekly or monthly injection. Both agents are administered usually in the abdominal area as a liquid, and upon contact with bodily fluids becomes either a solid mass in terms of the sublocade range or a gel-like substance in the buvidal range. Now, what then happens is it slowly diffuses from that injection point, and it has a long-acting action. It has a depot effect from that. Now, they both need to be administered as subcutaneous injections, because if they get administered as an IV injection, what would happen is you would get occlusion, possibly local tissue damage, and the risk of thromboembolism. So this next table shows you all the different preparations of buprenorphine, opioid replacement therapy. In particular, with this slide, you would note that out of all those agents, there is one that needs to be refrigerated, which is the sublocade, although it can be stored at room temperature for up to 28 days. Now, that has just recently changed. Prior to that, you could only store at room temperature for 7 days. So we found that at our site in the pharmacy, it was very difficult to coordinate the supply of these to patients, because they didn't always attend their dosing appointments, and in which case we had to actually discard those items because we couldn't guarantee the efficacy. Now, the 28 days is definitely better, gives us a bit more room, but in saying that, still, it's still very difficult to coordinate. So in terms of commencing Depo Grippanorphine, just like any other long-acting Depo product, it's an unsuitable product to initiate patients on. And the reason why that is because any rapid dose increases is not really reflected in the plasma level immediately. And you can also imagine that if a patient had never had buprenorphine and you injected them with buprenorphine, it's very difficult to remove the product once they experience any adverse effects. And there is data to show that you can remove sublocade via surgical excision, whereas there's no data to show that it can remove buvidal. It's on the PBS for treatment of opioid dependence. So anyone who falls in that criteria will get subsidy for it. Now, with pharmacies will traditionally charge fees for supplying buvidal, and doctors obviously would be charging consulting fees as well. So in terms of titrating, we would normally recommend that you would titrate using sublingual buprenorphine. Once the patient reached a maintenance daily dose, buprenorphine depot could be utilised on the next day, pretty much, as long as the patient reached maintenance doses. So when you look at the corresponding doses for buprenorphine depot, buvidal has a wider range of agents to tailor for the different maintenance sublingual buprenorphine doses, as you can see here. So there are obviously different, depending on whether it's weekly or monthly, you would give different doses depending on that daily sublingual buprenorphine dose. Now, that's a little bit different to sublocade. So sublocade, if you were using maintenance sublingual buprenorphine anywhere between the range of 8 to 24 milligrams a day, you would still use the same initiation regime, which is 300 milligrams monthly for the first 2 months, and then 100 milligrams monthly after that. And you would titrate depending on whether you've reached your treatment goal or whether there were side effects. So that's right. So you would increase that dose, or you would decrease the dose depending on those side effects. The other thing is that you would decrease the dose if the patient wanted to come off the therapy, or if they wanted to just reduce the dose. So supplemental doses are generally not required. So things like breakthrough cravings or breakthrough withdrawals, you shouldn't generally need to use sublingual buprenorphine. However, sublingual buprenorphine can be used, and this is usually during the initial dose titration, or if the patient was on buprenorphine and then they were initiated on a medication that that metabolized that buprenorphine, or if the patient missed out on their Depo dose, or if the patient was to express that they were experiencing stresses and therefore possibly showing drug-seeking behaviour. So those short-term supplemental doses can be used. So with regards to supplemental doses, Buvidal, if a patient was on Buvidal and expressed a need for supplemental doses, you could use another Buvidal Depo. Alternatively, you could use sublingual buprenorphine. However, if the patient was on Sublocade and they were expressing supplemental doses, the need for supplemental doses, they would normally be supplemented using sublingual buprenorphine. Now, the recommendation is usually 8 milligrams daily, and with Sublocade, there is a maximum of 14 days of supplemental doses. With regards to missing doses, if the patient had missed their actual scheduled Depo dose, they could continue using sublingual buprenorphine up until the scheduled dose. With regards to missing doses, the Depo preparation of buprenorphine offers a flexible dosing regime as well. So there is leeway. So even though they should be scheduled every 7 days for weekly and every 28 days for monthly preparations, there is flexibility. So if the patient were to want to go on holidays, or if there was public holidays that interrupt that dosing schedule, there is a bit of leeway. So the leeway for Buvidal weekly preparations is 2 days either side of that week. Buvidal monthly is one week either side of that dosing schedule. And with Sublocade, it's 2 days prior to that dosing schedule and for 14 days after. So adverse effects are usually seen during initiation and getting to steady state. Now, what the types of side effects that are normally seen during that initiation is the sedation and the mental impairment. So patients are advised not to drive or operate machinery during that period. In terms of safety profile, has a very similar safety profile to buprenorphine. There are, however, the local reactions at the injection site. So things like redness, pain, pruritus, but nothing that is treatment limiting. Now, drug interactions with buprenorphine. The key interactions are opioid agonists. So as discussed before, because buprenorphine has a high affinity for the opioid receptors, it's going to compete against those opioids and for those to occupy those receptor sites. So the opioids that are either initiated or already on, so the patient was already on opioids, they will experience withdrawal. But if they were on buprenorphine and opioids were initiated, likely it would be that those opioids would be rendered ineffective because they wouldn't be able to occupy the receptors. The interactions with sedatives is mainly like benzos or mainly benzos or alcohol, is that it can cause additional CNS depression. Other types of interactions to be aware of are interactions that occur via the cytochrome P453A4 hepatic enzyme pathway. So the potent inhibitors such as ritonavir and ketoconazole can increase buprenorphine plasma levels, and cytochrome P453A4 inducers can decrease buprenorphine levels. So it's really important if patients are initiated on these drugs that they are monitored, usually during initiation and during cessation of those agents. Other agents that can interact with buprenorphine are psychotropics that include things like SSRIs, SNRIs, TCAs, MAO inhibitors, due to them possibly causing a serotonin syndrome. So the overdose profile of buprenorphine is that if in an opioid-dependent patient, it is rarely going to cause an overdose on its own. However, as you would know, a lot of these patients are also taking other CNS depressants, and therefore that's when there is a risk of overdose. In terms of treatment of overdose, the treatment is with naloxone and supportive care. Now, it's not expected to have a higher risk compared to sublingual, but in terms of treatment for overdose, it does require extended monitoring just because of the long-acting nature of the buprenorphine in that formulation. So just to summarize, Depo Grippanorphine definitely offers the advantages of convenience and possibly the stigma related to opioid replacement therapy. There is the possibility that there is less costs, although there are, there are still costs in the dispensing of buprenorphine as well as the doctor's consulting fees or the clinic fees. It isn't the only option, and it doesn't necessarily mean that all patients will find benefit from it. And there is no evidence that it's more effective than the conventional sublingual counterparts. So it just offers choice for the patient. So that is pretty much all from me. So what we'll do now is we'll open up for discussion.
Hi everyone, Lisa, I'm off mute. So if you've got some questions, if you navigate to the bottom of the screen, you can see a little Q&A bubble box. Click on that and feel free to type your questions in there. Or you can also raise your hand if you've got a question you'd like to ask live. Any questions or comments are welcome. Okay, a question from Sally. Are you finding this is patient preferred?
Look, at the moment, because it's so new, I think everyone wants to try it out. So we're, as I've mentioned before, I've just seen the number of patients opting for this formulation just explode, and they're not necessarily keeping up with their scheduled appointments though. So despite it being just once a month or once a week, we are seeing that patients are not that committed to it. But for those who have continued with it, they're saying it's really good. I don't know whether it's patient preferred, because there are patients who do like that social interaction with their pharmacies. So it's not for everyone, but at the moment we are finding that people are very interested in it and wanting to try it out.
Thanks, Lisa.
That's okay.
Any other questions? Feel free to type or pop your hand up, raise your hand, and we can listen to your question. It looks like you might have answered everyone's questions, Lisa.
Okay, great. Thank you.
All right, well, that looks good to me. So thank you everyone for joining us. Oh, hang on, I've got a question.
Okay.
Have you found there was more of a preference for Buvidal, Buvidal. Sorry about this, guys. I'm not a
that's
pharmacist.
fine. Yeah, I know where this is
Or
going.
Sublocade for the monthly dosing.
Okay. Now with Buvidal, it was the first agent released. So when that happened, a lot of patients opted for that. So it's really difficult, I guess, to go from being on Buvidal and then being to be changed over to Sublocade. So at the moment, the majority of the patients that we have is on Buvidal. Buvidal is a lot easier to store. It comes in a smaller box. It doesn't need to be refrigerated. And also it doesn't have that expiry like Sublocade, which, as I mentioned before, was 28 days, but prior to that was 7 days. So I would say that the amount of patients that I have currently in the hospital or in our outpatient program are Buvidal patients. And mainly it's the Buvidal monthly, not the weekly. So they want the monthly options are the preferred options. And at the moment, I mean, Sublocade is so new though. Remember, it was only just released pretty much this year. So it's really very new, and it really hasn't had a chance to really, it hasn't had a chance to really demonstrate, what it can offer. So we'll just have to see, I suppose, this space and see what happens in the future. But at the moment, Buvidal is the leading agent.
Thanks, Dina. Dina's got another question. It is similar in our clinic as well. We only have 4 clients on Sublocade. The rest are on Buvidal. Thank you. Excellent presentation.
Thank you for sharing that.
Thanks, Dina. That's greatly appreciated. Any further questions from anyone else? If you're typing, maybe just raise your hand and we'll hang a minute while you type. All right, I think, Lisa, that might be a wrap. Thank you, everyone, for your questions, and a big thank you to Lisa for taking time to present this material. After you log out, you'll be prompted to provide feedback through a quick survey. It'll automatically prompt you. We would really appreciate it if you could just answer the couple of questions, as these help guide our future events. We'll be in touch again soon, and thanks again. We'll see you at our next event. Thanks, Lisa.
Thank you. Thanks, Catherine. Bye.
Bye. Bye, everyone.